Hello, welcome to you all. I'm Roy Noble, and it's a great privilege and pleasure to be here as a Bevan Commissioner on an auspicious occasion. Rosio cynnes I chi gyd, nawr ni di dod fel casgliad ar ddwrnod arbennig gyda'n gilydd. It's the showcase for the Adopt and Spread program, supporting adoption sites as they take Bevan exemplar innovations and innovators right across Wales. I've always been intrigued with innovators indeed. Where does the idea come from? Does it build slowly in the mind, or does it gradually, catch you unawares and a flash of inspiration in the middle of the night where you have to write it down on a paper before it actually goes? Now, when I was a young boy of 11, there were certain methods to help your innovation and to help your persistence, which is also something you need when you get an idea. And it came at the age of 11 when we tried the exam for the grammar school. And if you didn't show, a full 100% capability in the class, your parents got worried that you might not get to the grammar school. And they would try and add incentive, like, if you pass, you'll get a bike. Or if you go to the grammar school, the uniform is brown. If you fail to go to the secondary modern, where the uniform is navy blue. You've never looked nice in navy. But the great threat was that if you had ability and you were not firing on all cylinders, there was something that could be done. You could be taken to a specialist lady who specialized in the old medicines of the deep far country in Carmarthenshire. And she would do it to you. You would be taken to her parlor, and she would have three things in there: a bowl of hot water, a knife, and a towel. And she would cut your ear behind the ear until it bled. The belief was that once the blood flowed and was released, all your innovative capabilities were released as well, and all your intelligence was released as well. And you could become an Einstein overnight. And if you were very thick and tough, she'd do both sides for you. Actually, we never talked about it in case the police found out. But if you go to my village now, have a look around for boys my age who can't keep their glasses on. They probably have had it done. Now then, the Bevan Commission, if we think about that, the Bevan Commission has been leading the National Adopt and Spread program across Wales over the last 18 months, building on the work over the last 5 years with the Bevan exemplar innovators indeed. 15 of the Bevan exemplar innovators were selected to share their innovations with a new site, and over 50 new adoption sites have taken on one of those great innovations forward. Over 150 people have been involved in the adoptions and spread of innovations right across Wales as well. Now, let's not forget, this work has taken place during COVID-19, and the participants have had to work exceptionally hard, over and above what they normally do. This is the extra mile. And it's, to make that impact and to ensure that we all learn from the program. In the mechanics, there is a panel of project members who participated in the Adopt and Spread program with us today, plus guests. They will be ready to answer questions. So put your questions in the chat box, and the host will make sure that the question is asked and then answered, hopefully. So be ready then. Be interested, be enthralled, and be inspired by what we have today. Diolch yn fawr iawn.
Welcome everyone to this session. The Adopt and Spread programme is a groundbreaking programme invented here in Wales. It brings together professional networks from across the whole of the healthcare economy to share innovations that were derived from our very own Bevan Exemplar programme. These achievements are very impressive, given the fact that we've endured a period of COVID, high levels of stress, and redeployment of staff. So the gains that have been made by each of the programmes you'll see today are truly impressive. You'll see overall 13 Bevan exemplar innovations, over 40 active adoption sites, involving 150 people supporting each other to improve performance. This is something quite exceptional and quite inspirational. The Bevan Commission would like to applaud all of our exemplars and all of the members of the Adopt and Spread programme. Please remember to do support Bevan, do tweet and message during the day, and share your best practice, because this is the true heart of what we do at the Bevan Commission. Thank you and enjoy your day. I'll hand over to your host.
Hi there, welcome to the session on narrative reporting. It's an absolute pleasure to be here and chairing the session. My name is Rob Warford. I'm the Chief Scientific Advisor for Health for Welsh Government. It's a privilege to be here with a really fantastic panel. I'll let them introduce themselves, and I'll start with Debbie, then Mike, and Rachel, and Helen, Laura, Greg, and then Kate. So in your own time, if you can introduce yourselves, that would be fantastic. Thank you.
Hey, my name's Debbie Sidney. I'm a clinical liaison biomedical scientist, and I'm based down in Carmarthen.
Well, I think we've lost Debbie, so that's our first hiccup of the day. So I'll go to Mike, then Helen.
So I'm Mike Simmons. I'm the clinical lead for microbiology services down in Hywel Dda, and I was the exemplar that originated some of what you're going to see today.
Hi, my name's Helen Booth. I'm a senior biomedical scientist specialising in clinical liaison, and I am based in North Wales.
Thank you, Helen.
Hi, afternoon. My name's Rachel Annett. I'm a clinical liaison biomedical scientist based in Cardiff. As a group, with the exception of Dr. Mike Simmons, we all have a background as biomedical scientists in microbiology, and we're now all working as and also developing the role as clinical biomedical scientists.
Hi, I'm Fatima Dia. I'm a senior clinical biomedical scientist based in Cardiff.
Wonderful, thank you. I don't think we've had Laura, Kate, or Greg.
Hi, my name is Greg Williams. I'm a clinical liaison biomedical scientist based in Swansea Bay Health Board.
Hi, I'm Laura. I'm a senior clinical biomedical scientist and I am based in Cardiff. Hi, my name's Kate Baldwin. I'm a clinical liaison biomedical scientist in Cardiff.
Thank you. And Debbie, can you join us? Can you hear us?
Yes, hi. My name's Debbie, and I'm a clinical liaison biomedical scientist based in Carmarthen.
Great, thank you very much indeed. Look, I'd really like to encourage people to use the chat bar to ask your questions. We have a video now that will go through the work, and we'll come back then for some questions and answers. So thank you.
I always felt that the reports going out that are interpreted as they should be, as we expect them to be interpreted. We have a report, it's on the screen, it's on a bit of paper, a hard copy, and that we assume that the user fully understands what we're saying. So it was really fascinating to see it on the other side, that really what really happens is that there is a wide range of interpretation of our reports, and sometimes misunderstood.
And this is what really sort of got it for me, was that it made people ask the right questions. So it wasn't just about getting attention, it was making them think differently and want to go out for more information. The use of narrative, actually, in some sense, you could say it's cheap as chips. It's just words. I know it's not. It's people behind it. But it just goes to show you don't have to pay for fancy stuff that's shiny. Sometimes the most simpler things really make the difference. And for me, this is what the narrative stuff is about, and the clinical liaison roles with it. It's simple stuff. It is communication. That's it. In a nutshell, it's expert communication, but that is what it is. It's comms.
Is that through dialogue and conversations that we're having with this narrative authorising, we can spread it to, obviously we're doing work with wound swabs and genital swabs, and as it sort of branched out into other sample types, it's starting a conversation with clinical teams outside of microbiology, and ultimately, if we can build relationships and start conversations, then these things will build into I suspect, you know, we'll find things that we didn't know needed doing, and there'll be surprises out there. But it's that blue sky thinking of just talking to people we don't normally talk to, and collaborating and making a better service overall throughout the NHS, not just within microbiology and Public Health Wales.
Yeah, that was a great video, very well put together. Thank you, and lovely to see David Hayburn with probably the second best beard of the session. So let's get to some questions now. Really looking for some questions in the sidebar. I think the prize is a Kit Kat Chunky for the best one, but otherwise it will be me asking the question. So maybe a first one for Rachel. Rachel, it'd be great to get your perspective of, you know, what is narrative reporting?
Okay, well, in my view, narrative reporting in simple terms is exactly as the name suggests. It's the addition of a narrative to a formal microbiology report. Historically, microbiology reports have always been a statement of hard facts presented in a very consistent way. This, however, doesn't necessarily mean that this format of reporting produces results that are easy to interpret, or even that answer the question that a requester may actually be asking, whether that's in primary or secondary care. Whilst the laboratory are obviously producing an accurate report, we have come to understand that without reflecting on the report in the clinical context, the report may be viewed as confirming infection and or recommending the use of an antibiotic, which in reality may actually be unnecessary. Comments on microbiology reports, it's not a new concept. Requesters will have been familiar with observing agreed scientific comments which have been added to reports automatically by our LIMS system when the results meet certain criteria. However, it could be said that these comments don't always necessarily reflect the clinical picture given on the request form, and at times can even appear to contradict the reported results. Narrative reporting, it aims to introduce the patient's story into the formal microbiology report. This, I think, takes the report from just a statement of scientific facts or findings or results to a document that aims to explain what these scientific findings might mean in the context of requesting information provided, and also with any other information or intelligence that may be already available to us as authorisers as we report the results. This can include information such as previous sample results, relevant patient history, and things like known antibiotic allergies. Thus, narrative reporting seeks to review the clinical information written on the request form, and we report then in light of that information supplied. We add narrative in the context of the clinical information and seek to answer questions posed or address difficulties encountered by requesters in interpreting the results. This gives a more targeted report relating to the specific patient presentation, and also we seek to engage the requester to consider the relevance of the results being reported and ultimately consider then the accuracy of treatment options. That's narrative in a nutshell.
Thank you very much, Rachel. That was very comprehensive. So I'm going to go to Laura now. I think that was really wonderful, Rachel. I mean, you clearly articulated the benefits of contextualizing this information for the benefits of people using the information. But Laura, is there anything you want to add in terms of, why do narrative reporting? What's the sell?
Yeah, so I think Rachel has summed it up brilliantly. That's the service that you could supply. So why I think that someone should do it is because it is the type of bespoke and tailored service that all of us came into healthcare to do. But we know that over time, as demand for microbiology services increases across the country and the UK, it can be difficult to continue to provide that level of personal service with a growing number of samples. We also know that there has been lots of discussions about demand management, and perhaps some sites find themselves in with financial pressure. So for me, I think narrative reporting is a solution to all of those issues, because it's a way of opening your dialogue with your users directly and asking them whether this is the best use of the service that microbiology, can provide for them. And it's a way of targeting when we think perhaps we needed more detail, or the way that our service has been accessed has been perhaps suboptimal. And it's about increasing that education and that dialogue. And then, later on, we'll hopefully talk about the results we've seen. But, yes, with our time and input, we can make a difference. But it's not much more than that. It's bespoke comments. And also from a microbiology accreditation point of view, we obviously have to be accredited by UCAS to provide this clinical service. And all of this provides lots of evidence of user engagement that's not just been done, once a year with a user survey. It's daily consistent engagement with our users, so that together we can provide the best service possible for our patients.
That's really excellent. Thank you, Laura. So you're reducing low value things and you're increasing value in what you're doing, and also you're providing a really high quality service in doing so. So that's super.
Exactly.
Thank you. So I'm going to go to Kate now, and Kate, I wonder if you can give us maybe a brief overview of how do you do it? How do you report narratively?
We use a comprehensive spreadsheet of comments that were constructed by our team that cover a wide range of microbiological and clinical scenarios that may be relevant to a urine sample. It's important to note that our ability to effectively narratively report depends on the quality of the clinical information that we're given. We need this in order to advise and comment on the relevance of the microbiology to the sample and the patient. So we review this clinical information, any relevant history, take into account the patient demographics, whether they're pregnant, for example, the sample type, and any current antibiotic therapy. We then technically validate the sample, looking for any inconsistencies in the antibiogram or the identification of the organism, and also looking for any evidence of antibiotic resistance. At this point, we limit the antibiotics we wish to release on the report in an effort to prevent inappropriate use of antibiotics. And we make sure any antibiotics the organism is resistant to is clearly shown on the report. And this acts as a constant reminder and awareness to clinician that the resistance is very much out there and to be mindful of this. We then choose our targeted comments in the spreadsheet, and this is where we amend and personally tailor the comments of the patient and the clinical information in question. And by doing so, we then create a narrative dialogue between us and the clinician. The dialogue can contain references to national guidelines or recommendations, general advice around interpreting the sample. And we really do this in an effort to try and prompt and inform and educate clinicians of best practice and ultimately influence their decision-making for the better and provide a more effective evidence-based care for the patient. One way we have managed to influence decision-making is by strategically placing our comment before the antibiogram on the report, because we found that from a user point of view, the thing that was influencing behaviour was the list of antibiotics. The doctors stopped scrolling down the screen once they had viewed the sensitivities, and any comments at the end were simply not being viewed. Once we were comfortable with this process, we were then able to use our scientific knowledge together with the UCAST antibiotic guidelines, and we created standard operating procedures, training packages, quality management systems in order to fulfill the governance around narrative reporting and ultimately help spread the concept around the network.
Thank you, Kate. That's really helpful. So a real systematic approach, and then using the feedback to adapt what you're doing to get the maximum impact. Really, really great. Thank you. I can see good use of the sidebar coming along, which is really encouraging. There's a really nice comment about, let's pick that up. I'm multitasking now is never a good thing. There's a comment here from Rachel Chalmers about saying this could have good effect in the cryptosporidium reference unit, and I wonder what areas do you think this could have an impact on in NHS Wales or wider? So I'd like to have a go at that. Don't all answer at once.
I think I'd bring Helen in at this stage, if you don't mind.
Okay, Helen.
Yeah, so I think in North Wales particularly, we realised that there was quite a lot of genital samples being tested. So in effect, we have tried to adopt narrative reporting alongside genital sampling as well. It's still in the very, very early days. Probably further down the line, I'll be able to perhaps discuss this a little bit more. But yeah, we hopefully will see similar effects of urine reporting as down in genital sampling as well.
Fantastic, thank you very much. So I've got a question in the sidebar from Rosie. Has the increased time per report to authorise issue reports, balanced by a reduction in the number of specimens submitted by phone calls or submitted for clinical advice, has that required a net increase in clinical microbiologist time? So who's that question for? Is that a question for Mike?
Yeah, I can try and pick that up. It does take more time. There's no doubt about that. We actually I did some timings early on when we were in the early phases of this. But the bottom line is we found that the engagement that we put in via the narrative goes to a much broader and wider audience than we can on an individual conversation. And I think on balance, the feedback we've had is that the numbers of calls coming through have been more informed as a result of what we're saying. So they often, it may be a case of coming back to pick up the conversation that we've already started. And the thing about narrative reporting is it does become a conversation starter, I think, throughout the process. We are even now seeing on some of our samples an ongoing discussion between the patient, the clinician, the microbiology lab that coming through with follow-up questions or follow-up issues that they hadn't seen the first time round on the report. Whether I've not done any direct data capture to see whether the calls are going down. Inevitably, as everybody picks up, there's more and more requests for more and more bits of microbiology all the time. What we have seen is this huge reduction. It's now, you saw in the introductory video, 66,000 specimens a year is for 2 health boards. That's North Wales and Howell Dar. With Swansea coming on board, we're now picking up their numbers from there, and we'll be looking at what's going on. We certainly see the improvement in the clinical information coming through on the request forms within 3 months. And when we've analysed retrospectively, if you look at the papers that are highlighted on the website, that the numbers fall in that 3 to 6 month window. So there is a balancing constantly going on here, but we're not going to fool anybody. It does take more time, which is why I'm delighted that we've now got 6 biomedical scientists who are taking on this role, because what Public Health Wales recognised is there is a real benefit in the quality of what we're putting out back to the patients, and that's reflected in what we get back in. So the whole thing is a quality improvement process, which we're frankly delighted to be part of.
Thank you very much, Mike. I apologise, my signal, I don't know if others, seems to drop off and restart again, which is great fun. Thank you very much. Okay, I'm going to ask another question. Then I've seen a very nice question again from Rosie in the sidebar. So, whose idea was it? How did you figure out this would be a good approach to take? Who'd like to have a go at that one?
That is for me, really, because I think that's where this whole thing started. I'm not going to try and fool anybody. We didn't invent this. This came along fortuitously as part of a complex adaptive system. I've long had a fascination with complexity and complex adaptive systems, and the healthcare system is a complex adaptive system. So if you nudge it, you squeeze it in one particular way, it'll move in a particular direction. And that was what I came to the view that we were trying to reduce E. coli bacteremias. Howell Dar had the highest rate, and it just kept on going up for the whole of Wales, possibly the whole of the UK, and nobody could really explain why. But I just decided that, having challenged my clinicians about taking a complex adaptive approach to managing healthcare associated infection, that I challenged myself and said, well, what can I do that's going to make a difference? And the answer to that was, I need to start looking at urines in particular, because 50% of the E. coli bacteremias are caused by a urinary tract infection. And I need to read what people are saying and respond to that. And that's all I did. I started that direct interest in, particularly in urines at the start. And I started nudging, nudging or slapping. So where there was good behavior, as in lots of good clinical information around UTI signs and symptoms, then I would reward that with a comment in one direction. If, however, it was poor practice and all we were getting is query UTI, dipstick, nothing at all, then I would tell the clinicians off and say, look, this isn't good enough. We need to think about X, Y, and Z. And because I'm an elderly git and can get away with it, I was downright rude sometimes, and I recognize that. And I have modified my approach. So, confession is good for the soul. I have modified my approach and been more thoughtful in the way I perhaps put those comments on there. But as I was saying earlier, they're appreciated. And a year into this program, as we were busily watching the E. coli bacteremias, my laboratory manager in one of the labs said, we're getting a lot less urines than we ever used to. And when I inquired, he said, well, we used to get however many on a daily basis, and it was dropping like a stone. And so we turned the focus from looking at the E. coli bacteremia rates to look at what was going on with urines. And when we looked back, we discovered that, that within a year, we were losing 1,000 a month. We'd gone down 1,000 a month. At the end of the 4-year windows, we'd gone down 2,000 a month for our laboratory, which, when we doubled it up from a North Wales point of view, was again, we got the same sort of number fall. And the figure of 66,000 is where we've currently got to with those first two. So the innovation was the comment, putting the comment there, and the other key factor was the placement of the comment, because I watched junior doctors on the ward scrolling down the screen, looking at the microscopy followed by the culture, and then they came to the S's and the R's, and that's all they were interested in. And of course, the comment traditionally from microbiology or any of the sciences is down the bottom. And what we did, we moved it and we relegated sensitivities to the least important part of the report, because we wanted them to take on board what we were saying first before considering at that point whether they needed an antibiotic. So that was the innovation, but it was purely fortuitous, and it's had this remarkable effect.
That's really helpful. Thank you very much, Mike. Also, a nice bit of Dale Carnegie in there about a spoonful of sugar being less than a gallonful of, or attracting more flies than a gallonful of vinegar, I think. Very good. We've got a lovely technical question this afternoon. So, does the clinical information come in via the request form, or does your LIMS pull across the clinical record, or is the clinical microbiologist collating across multiple electronic systems? What a great question. Who'd like to have a go at that?
I'm sure Laura could answer that one. Or go on, Kate's going to. Yeah. Rachel.
Yeah, I have just put a little bit in the chat bar about that. It's really a combination of the two. So we take clinical information from the provided request form whilst using the LIMS system to look at previous patient history or patient samples and patient history and departmental history that will be on our LIMS system. So we look at a combination of things that are provided on LIMS as well as what's come in on a paper or electronic request form.
Thank you. Very well answered. Thank you, Rachel. Another nice question is from Heather. It's the first time we've had COVID mentioned. So just a question for you, I think, Mike. Are these reductions in numbers a reflection of the COVID-19 pandemic?
Yeah, if they look through at some of the data on the outputs we've put on the website for you, we saw a huge COVID effect in March and April last year. But the figure of 66,000, I calculated up to, although the data goes all the way to March of this year, for that 66,000 reduction I'm talking about, I'm only talking from when we started in 2014 to February 2020. So this isn't a COVID effect. There was a definite COVID dip. There may be, when you look at if you look at the graph under the outputs tab, there's a series of different outputs under the outputs tab. We've shown you what the effect was, and it may be that although we think from a micro point of view our numbers are getting back to normal, there may be a COVID legacy in these urines, in that it may have reset the baseline somehow, because of course GPs and secondary care throughout the past year, the 18 months, have been working in a very different way, and so there possibly is a legacy from it, but the data of 66,000 does not include the COVID year.
Thank you very much, Mike. That's very helpful, and incredible this work's being taken through the pandemic as well, successfully so. Got a nice question here from Tom Ashford from Pfizer, who's been very positive about the work. Have you captured markers of AMS behaviour, and if so, has the Wales Mycology Reference Centre, Lewis White, come on board with this approach? So a name check there for Lewis White. Who'd like to answer that one?
Again, I can, in as much as I'm the only person who's done any sort of analysis on the antimicrobials, we think, so far, and it has been limited. What I can say is that, and I think I've reflected on there, but we haven't published this work yet, and we want to go over it again. Both myself and my colleague Mark Temple, who was our epidemiologist on the original papers, independently worked through and looked at antimicrobial resistance for urines. We were very specifically picking up on only urines that had the full set of antimicrobials that we run first line, so that to try and maintain a consistency in there. What both of us showed was that for Hywel Dda, in the 2-year period before we started narrative reporting in September 2014, was that there were 2 step changes in increasing antimicrobial resistance. And then up to when we last had a go at this, because it's hard, and I need a lot of somebody else's brain to work on it, frankly. I think it was September 2018 when we both had a go at it. And up to for that 4-year window from September 2014 to September 2018, there'd been no further increases. It had plateaued. It hasn't gone down, but it had plateaued. And I know Greg has been looking at a variety of papers where others have looked at how various things working from a microbiology point of view, and you can see them going down, but I can't remember the details. I don't know if that means Greg wants to come back.
Yeah, of course, Mike. I think it was, serve my memory now, I think it was Davey et al. And his team, and they looked at over 80 studies from 19 countries, I believe. And they noted that applying a persuasive narrative approach and a restrictive approach where certain antibiotics are suppressed, they noticed a large reduction in antibiotic resistance and a decrease in hospital-acquired infections. We quite early on in the adopt and spread. Consistently, we've been doing it now from January of this year, and we'll be keeping a close eye on the prescribing practices of the primary care to see if there's been any difference in whether they've plateaued or indeed reduced over this time frame. But as I said, it's quite early on, and we're going to need a good number of months to get some good figures.
That's very helpful. Thank you, Greg, and thank you, Mike. So maybe I'll try and elicit an answer from Fatima around, from a scientist's point of view. How did working on this project change your thinking about the use of results in care settings, about your, the knowledge mobilization that you're creating?
So when I started this, working with this project with the narrative reporting, I had a bit of an insight that what the others have alluded to, that the clinicians across primary and secondary care, they were simply more interested in the antibiotics that were available on the reports. So our reports can encompass a wide range of results, from a complete negative report to a urine that requires a culture and that can yield, again, no growth to mixed growth to a pure growth of a potential pathogen, or simply it just could be an organism of the regional flora and a contaminant. So my way of thinking changed from a more lab-based perspective to a more patient-centric way of thinking. So when I'm authorising these reports, I'm constantly thinking, what does this report possibly read or look like to the user? Could they be prescribing antibiotics where, given the detail that we've got, it might not be clinically indicated? So it's important to note that, where we apply our comment sits between the organism being reported and the sensitivities, just to make sure that the users are reading what we're trying to convey. So once we've done all the checks, technical checks, and I'm happy with the comments that I'm putting on the report, it's good to know that report quality is of the highest standard that we could possibly provide, given the information that we've had from the user, then also helping them aid with their decision making with the clinical management of the patient. So yeah, my way of thinking is definitely more patient centric and making sure that the report is more meaningful to the user.
I don't know if you can hear me. My lovely hanging computer is it's great fun this afternoon. Another question from Tom. I'm going to round off here, and then we're going to go to another short video. So I thought this was a nice question around how can you embed this? How can this be embedded in telemedicine platforms? So it says the majority of patients being seen for UTIs are now online on the phone. So who'd like to have a go at that one?
Flip me, some people do ask them, don't they? Telemedicine isn't something that we directly get terribly involved in. So you're asking us to invent something for the GPs or the secondary care clinicians. Well, of course, all of our reports are available on screen anyway. So the opportunity, I guess, from a patient point of view, is to be shown the report and be shown the comments from the microbiologist. And potentially, I guess that can be very powerful, because so often the person who's in front of the patient at the time is getting the beating up because the doctor or the nurse who they're liaising with won't do what they want them to do, and they like to everybody likes to turn to somebody else. And in that respect, from a microbiology point of view, not from a brain surgery point of view or anything else, but from a microbiology point of view, we're seen as the expert. And so the ability on screen to be able to show, like I can show you what the microbiologist is saying, might hopefully get into the brain of both individuals. And certainly, what I've learned over the months and years since I've been doing this, and the complexity side, is the fact that the reason why we've adopted it as narrative and storytelling is because that's what we are as individuals. We are storytelling animals, and we believe things once we own them, and we own them by hearing them interacting with our brains, as it were. So presenting this stuff online to a patient may well give an opportunity that we haven't thought of up till now.
Very good. Thank you very much. So we've got a bit of the future and a bit of behavioural science coming in there. Really good. So we're going to pause now and go to another video and then come back for a second and final set of questions and answers. So thank you. But I'd like to encourage colleagues to keep using the sidebar. If I can't get through the questions, and if I can ask our panel to try and answer them as well, that would be great. Thank you very much. Okay, we're back. Hopefully you've all had a time to have a cup of tea and a stretch of your legs. Brief one of that. Okay, so let's now talk a little bit more about the future and what's the art of the possible. We've touched upon this ever so briefly, but Debbie and Greg, I wonder if you could tell us a little bit more about the work in the future and your work on genital swabs, and Greg maybe on wound swabs.
Rob, do you want to on genitals, because that's been my little project.
Yeah, that was what I was just going to say.
Oh, thank you.
Yeah, so just a little bit of background regarding why we decided to look at genitals. So for some time now, our clinical teams and laboratory managers have noticed that we're processing quite a large number of genital samples within Wales. This was particularly noticeable within North Wales for some reason, which may itself warrant further investigation as to why. But I obtained some data from our quality team, which confirmed the thoughts of the managers and consultants. So the dates I looked at suggested that the total workload for genital testing in North Wales was 9%, as compared to 4 and 5%, which was from our colleagues in Cardiff and Swansea. So we decided to target North Wales for this adoption of genital narrative reporting. As we'd already seen such a positive effect with urines, we started to wonder if we could actually mirror this effect with genitals, with the goal of driving down sample numbers, improving patient management, and influencing a change in clinical behaviour, particularly in the long term. It was clear when I started to look more closely at the quality of the clinical details, very much like Dr. Simmons from at the very start with urine reporting, that these clinical details were either incredibly poor and very vague, or that the diagnosis was actually quite spot on. So working with NICE guidelines, I set about developing some narrative comments, linking with the clinical details with the laboratory diagnosis as well. Need to say that NICE guidelines exist to offer an excellent way of confirming a diagnosis in the clinical setting, rather than actually waiting for a laboratory report. So saying that though, many are still in the mindset of testing and waiting for knowledge of that direct therapy, which in some respects, I suppose, is what we've been trying to encourage for a long while, as we all have a role to play in antimicrobial stewardship. But in this particular setting, there are many occasions where a diagnosis of a vaginal infection is incredibly obvious, regardless of the microbiology. So the patient presents with textbook symptoms, and given it can take up to 4 days to release a report, we have to question whether this approach to wait is actually in the patient's best interest at all. The comments I looked at and devised seek to question whether microbiology investigations actually need to take place at all, given the excellent quality of the clinical details provided and the confirmation of their suspected diagnosis. So if they suggested the lady had an infection of thrush, could they actually go down that route of empirical management rather than send us a swab in? The comments also seek to educate and remind the requester of likely presentations of specific organisms. We offer solutions in use of point of care, in particular monitoring of pH to aid in differential diagnosis. And also we discuss the findings, the significance of our findings, which on some occasion may actually be purely incidental and not relevant and not require any treatment at all. We also use it as an opportunity to suggest appropriate referrals to possible to other clinics, such as sexual health or gynecology. Each comment can be adapted and is essentially tailor-made for the individual to improve both the patient experience as well as their management. So in essence, for many uncomplicated, and I need to stress uncomplicated genital infections, we can often pinpoint a clinical diagnosis based on the presentation alone. Armed with this knowledge, a GP could advise a lady to actually test, diagnose and treat one of the most common causes of infections, actually in the comfort of her own home. It is still very early days. I'm hopeful that we can focus the new clinical liaison team to achieve a standardised but flexible approach to genital narrative reporting as soon as possible. So hopefully we can start to see the benefits filter through to both primary and secondary care in the very near future. I think my colleague Greg is doing some more work and wants to discuss possibility of wounds.
Thank you, Helen. I suppose, well, another area where there is suspicion we are over-processing samples are superficial wound swabs. Currently, I'm working with the clinical microbiology lead for Swansea Health Boards, Dr. Brendan Healy, to establish narrative authorising of superficial wound reports for the Swansea Bay area, with the aim to disseminate narrative wound reporting throughout Wales. When you consider the World Health organisation has estimated that 50% of all treatment choices are unnecessary or inappropriately used. And with reference to wound care, a number of studies have suggested that treatments and care can be somewhat ritualistic in nature. Narrative authorising for these samples will be ideally suited. As a scientist working in a diagnostic laboratory, we have a very clear view of what happens to samples after they arrive at our reception up until the final report. But we have very little experience of what happens at the beginning of the journey. Why has the sample been taken? Is the wound infected? What information does the user really value? My role as one of the newly developed clinical liaison biomedical scientist posts will allow me to gain a greater clinical knowledge base and awareness to closely liaise with the various medical teams and laboratories throughout Wales in order to assess the initial stages of the sample taking. The information obtained can then be reported back to the consultants to help provide an enhanced service. Where are we currently? Swansea Bay receives on average around 18,000 wound swabs per year. Are they all necessary is the question. Currently, wound swabs are sent to the laboratory with a variety of clinical details provided. Sometimes there's nothing provided, and quite often you can have clinical details that are not relevant to the specimen taken. The specimen is processed and a report is compiled. The presence or absence of bacteria is noted, together with antibiotic sensitivities if required. My role will be to look at the end-to-end process in a wound infection, the initial assessment of the wound by the clinician, any initial treatment that's been started and the reasoning, the sample taken, the laboratory investigation of the sample, and the management of the wound. This will allow us to construct a bank of information that will help formulate narrative comments based on current guidelines, best practice, provide relevant information the requesting clinician ideally requires. By using a persuasive and a restrictive approach, as mentioned earlier, we can, and that's what narrative authorizing provides, we can give a nudge as to where the guidelines are to assess when a wound is infected, possibly guidance on when to take the sample, when to prescribe, fitting in ideally with the ethos of antimicrobial stewardship, using the right antibiotic at the right time for the right duration. All in all, this can only enhance antibiotic stewardship and provide a more personalised management to the patient.
Thank you very much, Greg. That was very interesting, and we look forward to hearing the progress for genital swabs and wound swabs as well. And I think there's enormous potential there. I'd be very keen to hear the panel's view, really, of where this is going and what you'd like to see for narrative reporting. Who'd like to chime in there?
Well, if none of my lot are going to answer that one, in Hywel Dda, as among the consultant body, we narrative report everything. So, although we've never done the number counting, we get into the habit of looking as described at what's coming in and then commenting on all of them. So ultimately, my vision is that that's what will happen across the whole of Wales. That everybody will be paying far more attention to the clinical information. I guess when I started microbiology, we inevitably did that because the report went out on the piece of paper that it came in on. So you were presented with everything. Nowadays, of course, it's booked in by one person, and somebody will have interpreted and may have typed what details are that are on the form in the computer. Sometimes they've got it wrong. Sometimes they'll have said illegible, and I haven't gone back to look at whether it's illegible or not. Nowadays, we've sort of effectively gone back to that, and we're looking directly, because we can within our laboratory information management system, we can look directly at the image on the request card. That's what I want people to do. Look at what the clinician is saying. And if it's rubbish, tell them it's rubbish, because if we don't tell them it's rubbish, then we're not going to improve the system. But if we tell them in relation to what you're doing, what you're saying, this probably means X, Y, or Z, then we're providing a better service. So we can't stop at urines and genitals and wound swabs. We have to do it with every specimen type. And again, Greg pulled out a paper where somebody's been doing something similar in biochemistry. So it's not something that is just for microbiology. And as Rachel said earlier, the cryptosporidium unit could be doing some of this. All of us could be doing this. All of us are potential patients, and all of us want the best possible quality care. So all pathology reporting should include narrative comment where we possibly can. And if we're having difficulty, tell people we're having difficulty with their specimens. Please give us useful information, and we will give you a fabulous service back. And that way you'll tweak everything, and we'll get as we've seen with the urines, you'll get the right specimens in on the right patients, and we'll stop wasting people's time taking specimens unnecessarily just because that's what they've always done up till now. If you look at the video from the GP on the website, Carwyn Jones, it was him in a meeting in Howell that said, I wonder if it's because we're dipsticking diabetic urines that we're then getting all of these. The diabetic screening service reasonably was looking for ketones and for protein. Ketones and sugar. What am I doing? Ketones. I told you I wasn't a brain surgeon. I'm not a GP either. Looking at for proteins and sugars, but finding leukocytes and nitrites and saying, oh, you've got an infection. Well, of course they haven't got an infection. They've got leukocytes and nitrites because there's bugs there, but they're not causing any harm. It was him that's saying that. When he goes off into his primary care practice and starts changing his behavior immediately, and me goes off in the other direction and said, we've got to change everybody's behavior in the same way. That's the future. Everything we send out should have a comment on it. The downside is we're only currently doing positives. We've got visions for doing negatives, and that vision, picking up on one of the questions, I think in the sidebar, is around some artificial intelligence process to pick off the easy stuff, i.e. the rubbish can be picked off by the AI, and we can keep training the AI to do whatever, and we can then, with the greater insights that our brains have, can pick off the more complicated on both the positive results and the negative results, because as the quality of the clinical information improves, my worry is we're not answering as many of the questions as we should be answering, because many of them are on negative samples that we haven't seen up till now.
Thank you, Mike. That was very helpful. Let me ask one or two questions before we wrap up. I'm not seeing any more. I mean, it could be my sidebar that's not working. But look, we've got two trains coming down the track, I think. A bit of a paradigm shift with pathogen genomics, that we've probably sequenced more pathogens than we've ever done before. And I'm sure that will expand out to a broader array of things that we will find important to sequence, as well as pharmacogenomics. So I think there are two trains coming down parallel tracks. I mean, there's going to be more of a need to be able to translate and contextualize very complicated information. We're seeing the birth of precision medicine right now. Do you think this is in the right place at the right time, or there's more need to be done? How would you adapt to precision medicine?
I think I would turn to Debbie for some of this, because Debbie is getting very much into genomics, and she's doing a sort of work with genomics currently. So I'd pass to her.
Yeah. Well, yeah, I mean, it's a very good point. And I think certainly at the moment, cancer genomics is being used fairly widely nowadays, and it is very complicated. And to be honest, even I think some of the pathologists in cancer research, in cancer, they get these reports, and they're huge reports. They can be sort of pages and pages long, and it's very difficult to pick out what is actually important and relevant to their patient. So I think actually getting into that mindset of having people from the scientific background sort of picking out and saying, actually, this is the relevant piece of information that we need, and this is what you need to know, is actually is going to be very, very useful, because it can get, as I said, it can get very complicated, and patients, you're giving sort of patients all of this information that means nothing to them. So yeah, certainly I think this, trying to sort of roll it out across the board is good, and getting into that the practice of giving information and relevant information in a good quality manner, and starting conversations. It's not about sort of, I think it's not about cutting people off and saying this is what you need to know. It is about starting a conversation, and they may well come back and say, well, what's this mean and what does that mean, and it does, and then you just sort of, you can get into conversations, you can learn more about the patient and what the clinician wants, and we can sort of feed back on those sort of things. From a personal sort of point of view, the whole process, we work on the benches, we get specimens in, we just look at the cultures, and sometimes you can forget that there is actually a patient at the end of that process. And getting into this sort of narrative or narrative reporting, it's opened up that clinical side, and you see the patient at the end of it, and I think it's very good to be doing that. And again, on another personal side, it's sort of reiterated and given more confidence to myself, and hopefully it will do to other biomedical scientists who try to come through, or hopefully will come through along this career path, because you are actually linking the knowledge that you've gained over years and your skills and experience, and you can actually see how that links in with clinical situations.
That's great. Thank you, Debbie. That was really, really clear. I got a final question for you then. So you're in an elevator with an executive from one of the health boards. What would be your elevator pitch for for narrative reporting for microbiology? What would you say if you had those 3 floors?
If you're prepared to give me 2 biomedical scientists to train, I can get your urines down by a percentage per month within a year. And that's effectively the pitch I made to my colleagues in North Wales when they were struggling some years ago, which started our journey off in being able to prove this concept the second time round in North Wales. So you give me a biomedical scientist. These 7 biomedical scientists are ace, and they have. You will not believe what they have achieved since they arrived in January. I mean, Helen has been doing it for a long time. She's been struggling on her own up in North Wales, and even with the struggles of one person doing narrative reporting, it was fascinating to see that the urines continued to go down, despite the fact that when we were doing it with 5 of us on a rotational basis, just one person in North Wales made a big difference. 6 more coming along from January, and suddenly they outstrip the quality of what I've been putting on reports. And I have, when I'm doing it at a weekend now, I have to be very careful to do it as good as them, because they pick up on so many of the messages that I'm not seeing, and it's been incredibly encouraging. So from a chief exec's point of view, if you give me 1, 2 biomedical scientists to train, you will see a huge difference for your service.
Well, that was excellent. Thank you very much, all. That was such an illuminating session, and some really, really great questions in the sidebar. I think Tom just nudged it on the Kit Kat Chunky. So I'd like to say thank you to all of our panel members. Very, very good session. I will draw that to a close, but please do keep in touch. I think there's a booth where more conversations can be had, but please do keep in touch and contact colleagues online. Thank you so much, and see you all again soon. Thank you. Take care.
Thank you.
Thank you.
Thanks, everyone.
Okay. Are we off now?
Just 1 second while I wait for confirmation.